Today's session is the role of e-prescribing in health IT safety, challenges, and solutions. We're going to review a few brief housekeeping items before today's session begins. For any technical questions, please type your questions into the questions or chat panels at the lower right of your screen. All telephone lines are muted during today's session. Due to the number of attendees, please use the questions panel to ask any questions that you have. You can use the questions panel to ask questions at any time during the session. We will have Q&A at the end of each of the 3 presentations today, as well as cumulative Q&A at the end of today's session. Slides and a copy of the recording of this session will be posted within 2 weeks at healthitsafety.org. And for general questions about the webinar series, please contact us at healthitsafety@rti.org. I'm going to turn things over now to Dr. Jonathan Wald to introduce the webinar series. John?
Great, thanks, Allison. This is Jonathan Wald. I'm with RTI, and I've been leading the work around getting the this webinar series up and running. Our webinar series includes 10 webinars that are focused on health IT and patient safety. They started in December. This is the second of 10, and they'll occur monthly through September of 2015. When you registered, if you said yes to being invited to the future ones, then you'll receive a mailing about it. These webinars are funded by the Office of the National Coordinator for Health IT. They're being conducted by RTI International, which is a nonprofit research organization. And this is part of a larger year-long project to develop a roadmap for a health IT safety center that's being conducted under the ONC. Additional project information as well as information about future webinars is available at www.healthitsafety.org. And with that, I'd like to turn it over to our moderator for today, Mark Graber.
Thank you, John. Welcome, everybody. My name is Mark Graber. I work on patient safety projects at RTI, and I'm really delighted to be moderating our roadmap webinar today. Yes, the cartoon you're looking at today always gives me a chuckle. This is from Jim Unger. And I put it in here as a reminder of just how far we've come in regard to e-prescribing, because it wasn't that long ago that we were all writing out prescriptions with all the challenges that created for our pharmacists and our patients. And you'll notice the date on here, 2002. It was the same time that Tejal was conducting her study on medication safety in ambulatory care that we'll be hearing about today. There were 2 factors that made Tejal's study remarkable in my view. One was the incidence of medication-related problems, which was strikingly high. I think 1 in 4 patients experienced a medication-related problem in her study. And the other was that the study focused on patients in ambulatory care settings. And this is one of the first patient safety studies to have that kind of focus, pointing out that it wasn't just in the hospital that patients were at risk. So we've come a very long way in regard to medication safety, as we'll hear about today. E-prescribing is a fact of life for many of us, maybe most of us. And not only is it widely used, it's actually something that both patients and providers value. I was just reading a study that came out a few weeks ago from Lauren Schleiden and her colleagues at the University of Pittsburgh. Lauren, I hope you're on the call. It was a survey of adults over 50 about electronic prescriptions. Remarkably, 3/4 of the patients had received medications prescribed electronically, and 93% said they liked the process. 68% said it improved the quality of care. And a fascinating observation from the study was that e-prescribing seemed to somehow change the dynamic between physicians and the patients for the better, for example, by improving communication. On slide 5, we have the 3 outstanding speakers aligned for you today. Tejal Gandhi will be presenting an overview of medication safety in ambulatory care. Erica Abramson will discuss the challenges of e-prescribing, and Ajit Davli will be reviewing the electronic prescribing enhancements put in place by a large e-pharmacy system, SureScripts. Each presentation will be about 25 minutes in length. We're allowing 10 to 15 minutes after each presentation for questions and answers. So please feel free to submit questions through the GoToWebinar panel on the right during the presentations, and we'll try to get through as many of these as we can. So let's get going. I'd like to formally introduce our first speaker, Dr. Tejal Gandhi, President of the National Patient Safety Foundation and the Lucian Leaf Institute. Tejal is one of the nation's leading advocates for patient safety and has participated in any number of major projects focused on education, patient safety innovations, and interventions at the NPSF with the Joint Commission, the National Quality Forum, and the Office of the National Coordinator. Tejal trained at Duke, received her MD and MPH degrees from Harvard Medical School and the Harvard School of Public Health. Prior to assuming the reins at NPSF, she was the Executive Director of Quality and Safety at Brigham and Women's Hospital and Chief Quality and Safety Officer at Partners Healthcare. Many of her research studies have focused on medication safety and safety in ambulatory environments. And Tejal, we thank you so much for being with us today.
Thank you, Mark, and thank you, John, as well, for inviting me to be here today. So I'm going to talk today about ambulatory medication safety, risks, and opportunities. And I wanted to start by talking about really what is ambulatory. And, you know, when I think about this, I think about care outside of hospitals, which most of the studies, and the studies I'll talk about today, have been done in primary care or specialty practice settings, but I think it's important to think about all of the other settings that are out there, such as ambulatory surgical centers, dialysis centers, nursing homes, rehabs, home care, et cetera, where medication safety is a really crucial issue as well, and we're just starting to learn about what the issues are in those kinds of settings. Next slide. So what is different about ambulatory care? We all know ambulatory care is different from hospitals, but there's a couple of key differences that I think are particularly important when it comes to medication safety. So one, there's long feedback loops. In the hospital, if I prescribe a medication and the patient has a side effect, generally we identify that side effect pretty quickly. In the ambulatory setting, I might prescribe a medication and it might be 6 months or longer before the patient comes back and we realize that they've been experiencing an adverse drug event or side effect over that long period of time. When I show you the data that we did in our 2003 study, we actually had to create a new term for this kind of adverse drug event that lasted an extremely long time, but was not necessarily due to an error at the time of prescribing, but we felt there was an error in terms of how long it lasted, and that term we called ameliorable. So you'll hear more about that. Ambulatory care is episodic. The signal-to-noise ratio is low, meaning in a non-medication example, if I see 100 patients with chest pain, maybe one is actually having that heart attack. It's widely distributed, limited resources, and there's many degrees of freedom, particularly on the patient side. So an example of this is in the hospital I prescribe a medication, and yes, there's lots of steps in the hospital for the patient to get that medication, but it's generally quite controlled, whereas in the ambulatory setting, there's a lot of things that need to happen from the time the order gets into the computer, hopefully through e-prescribing, and the patient actually goes, picks up the prescription, has to pay for it, and then has to take it in the manner in which it was intended. Next slide. So some other data from ambulatory that I think is pretty important for medication safety. The typical primary care encounter, the average encounter is 12 minutes. The average time to first interruption, 18 seconds. And many patients are leaving with unanswered questions, and there's little time to do all that needs to be done. And you know, a particular example here has been the focus on medication reconciliation, particularly in the ambulatory setting, and many concerns by providers about the amount of time doing a really thorough job of medication reconciliation actually takes. And it could pretty much take up that 12 minutes for a complex patient. Next slide. The other thing about safety in particular in the ambulatory setting is that patients perceive the mistakes that are happening. This was a study from 2010 that found that 15% of primary care patients reported that a physician had made a mistake, often related to a wrong diagnosis, but then often related to a wrong treatment as well, which could include medications, and 14% changed physicians because of a mistake. Next slide. So what do we actually know about medication safety in the ambulatory setting? Next slide. So this is kind of extrapolated data at the national level that comes from some of the studies that I'll show you and from other studies, that there's basically 8 million adverse drug events in the U.S. per year, greater than 3 million preventable, and during this hour, over 1,000 adverse drug events are occurring nationally. Next slide. In the outpatient setting, as Mark mentioned, this was one of the first studies that really looked at adverse drug events in the outpatient setting, and it was based in primary care and based at 4 practices. And basically we found that 25% of primary care patients had an adverse drug event within a month after receiving a medication. And it's important to talk about the definition of an adverse drug event. An adverse drug event is a symptom due to a drug. So it could be anything from a mild episode of nausea that lasted a day to that was non-preventable, to anaphylaxis from an antibiotic that shouldn't have been given because the patient had a prior known allergy. So the preventability can vary as well as the severity in that term, adverse drug event. When we looked at this 25% of patients that had an adverse drug event in the outpatient setting, we found that 13% were serious, 11% were preventable, which means due to an error at the time of the order, and about 28% fell into that category of ameliorable, meaning there was no error at the initial time of the order. It was a perfectly appropriate drug that was prescribed, but the symptoms lasted longer than 3 months, and often due to either the patient not telling the provider about it, or the patient did tell the provider and the provider did not change anything despite the fact that there were plenty of other alternative options available. And 6% were both serious and either preventable or ameliorable. Next slide. So this is what we're trying to prevent, hopefully, with handwritten prescriptions. And some of those errors that I described to you in the previous slide were due to handwriting. Others were due to things like wrong dose and wrong frequency and those kinds of things. I'll just say that this is actually not Coumadin, because most people who see this see Coumadin, and it's actually Avandia. Next slide. So what do we know about prescribing error rates? So, I spoke about adverse drug events, which are symptoms due to drugs, but there's other studies that have actually looked at prescriptions themselves and tried to identify error rates on those prescriptions. So in this first study, almost 2,000 prescriptions reviewed from 4 academic practices, and the medication error rate on looking at the prescriptions was about 8%. And it was felt that having advanced computer prescribing checks, things like decision support around drug dose and drug frequency, would have prevented most of the ones with potential for harm. There was also a study of community practices that found an error rate of 37%, much higher, and legibility issues were very common in that study. Next slide. So when we think about e-prescribing, we think about the decision support that could potentially help mitigate some of these medication errors. This is just an example of a type of alert one might see in an e-prescribing system. Next slide. And I'll highlight 2 recent studies that have started to look at what the impact of e-prescribing is. So the first study looked at 15 providers before and after implementation of e-prescribing. This study had a very high baseline error rate of 42 per 100 prescriptions that went down to 6 per 100 after the study. And another study of a multi-specialty practice where errors went down from 18% to 8%, and the largest reductions were in illegibility, inappropriate abbreviations, and missing information. Next slide. So electronic prescribing with decision support has high potential for reducing serious medication errors. And so the real question is, how do we actually optimize electronic prescribing? I think there's a real need to improve the way the current decision support works. There's many concerns about over-alerting, for example, and so trying to figure out what the ideal alert acceptance rate might be, the best way to display alerts, and those kinds of questions I think will need to be answered as we go forward to make sure that we're maximizing the clinical benefits. Next slide. So just to give you a couple of examples related to this topic of optimization, the first was about how best to display messages, and then I'll talk a bit about over-alerting. Next slide. So this is a typical example of an alert that one might see in an electronic prescribing system, and it's got a red bar because it's a pretty important alert, and there's quite a bit of language in there. And there's other industries out there that have spent a lot of time really thinking about usability and human factors and how do we do alerting. And so the question I'll ask is, do you think this alert would be best for a really important high severity alert versus the following slide? Next slide. Oh, and my thing didn't show up. I'm so disappointed. Can you go to the next slide too? Yeah, let's go back. Somehow my imaging didn't work. So on this slide, imagine this warning with a large skull and crossbones on it. And so the idea is, do we need to think about the best ways to display alerts to make sure that we're really capturing the clinician's attention for the ones that are really important. Oftentimes, a highly severe alert versus one that is kind of a, well, you might want to think about this, but it's not so important, they may display exactly the same way. And so we need to think about really what the best options are for alerting and try to learn from other industries that have spent a lot of time, again, looking at user design and usability and human factors and all of those kinds of things to optimize performance. Next slide. So the other issue I want to talk about is over-alerting. And we know this is one of the biggest complaints that we hear from clinicians with inpatient CPOE systems and also with ambulatory e-prescribing systems. And so the question is, how can we actually optimize over-alerting? So a couple options that I'm listing here. One is creation of streamlined knowledge bases where only essential content creates an interruptive alert. We know that oftentimes it's kind of the kitchen sink approach, and every known drug interaction, for example, creates an alert, and that leads to a lot of challenges with over-alerting. And clearly there's a balance between sensitivity and specificity. But if you are too sensitive, you really get into the problems of over-alerting. Tiering is another possibility. So which alerts should be hard stops where you absolutely cannot proceed? Generally, from my experience, this has to be a very limited number of alerts because there's often clinical judgment and other things that need to go into decisions, but there's usually a small subset where it's absolutely contraindicated and you need to have a hard stop. Then which of your alerts should be interruptive, where you're going to require someone to actually explain why they're proceeding, or maybe have them talk to a pharmacist or do something before they can proceed. So it is an interruption to the workflow. And then the last is non-interruptive. And again, many systems don't necessarily have this kind of tiering, but this kind of tiering can be very helpful, as I'll show you in a second. And really the goal is to try to minimize the interruptions that have minimal clinical value. Next slide. So we did a study in the ambulatory setting looking at decision support such as duplicate drug alerts, drug disease alerts, drug-drug interaction alerts, drug lab, and drug pregnancy alerts. Next slide. And this study was done at Partners Healthcare in Boston, and an expert panel of physicians, pharmacists, nurses, informaticians, a group such as that reviewed all of the alerts and decided whether the alert fell into the hard stop category, the interruptive category, the non-interruptive category, or just shouldn't be displayed at all. Next slide. So here are some examples of level 1, which is hard stop. Level 2, potential for serious injury, is interruptive, and then level 3, non-interruptive, but would be displayed passively. Next slide. And this is an example of the hard stop type alert. Next slide. And this is an example of an interruptive, where you can see the red bar turned into yellow, and you can continue, but you have to actually provide your reasons for continuation. Next slide. So in the final knowledge base that was created, 2% of the alerts were level 1, 63% level 2, which are the interruptive, and 35% level 3. And we found that of 5,000 interruptive alerts, 67% were accepted. That's that last bullet. So let me just point out, so 67% of these modified alerts were accepted. If you look at the literature prior to this, most of the alert acceptance rates For things like drug allergy or drug-drug interaction, we're in the kind of 10 to 20% range at best. So to be up in the 60% range was a pretty significant improvement. And again, this was based on the streamlining, so deciding some alerts we weren't going to show at all, but then also doing the tiering. Next slide. So you can reduce alert burden by streamlining and tiering. We still need more research on what the optimal level is. There's always the concern, are we missing things? But what I would posit is if we're making sure people are paying attention to the most clinically important and actually accepting those, then we've really gone a long way in optimizing these kinds of alerts. Next slide. So the other topic I want to talk about in terms of, again, this concept of optimization is unintended consequences. And we know that every new technology introduces new errors. There was a study done that showed that 10% of electronic prescriptions had errors. So, you know, as much as I showed you that electronic prescriptions reduce error rates, we also see that electronic prescriptions do have errors, usually new errors. And in this study, it was found that 1/3 had potential for harm. Most frequent were omission errors. And I also think what's quite interesting about this study is that there's significant variation across different vendor systems in terms of error rates. So design and implementation of vendor systems by the clinicians, and you know, there's probably issues with both the design and the implementation, but there was a lot of variation there. Forcing functions, decision support, and calculators were felt to have the ability to reduce these errors, and it's really the message that there's always a continuous improvement opportunity when you implement technology. It's pretty rare that you can implement the technology and you're done, but it's really important to try to identify some of these new errors that may be occurring and have that continuous improvement occur. Next slide. So I've focused a lot on e-prescribing, obviously, because that's the topic of the webinar today, but I want to bring up one other point that's pretty important around medication safety in the ambulatory setting, and that's the issue of non-adherence. And I alluded to that initially when I talked about the degrees of freedom that the patients have. And you know, we really need to not underestimate how important this issue is. There's estimates that 125,000 Americans die annually due to poor medication adherence, significant number of hospital admissions as well as costs related to non-adherence. And the third study I found quite interesting. In looking at almost 200,000 newly prescribed e-prescriptions, only 72% were filled. And you know, it wasn't the you know, PRN topical steroid for a rash that went away. It was prescriptions for chronic conditions such as hypertension, diabetes, and high cholesterol that were not getting filled. So as you think about care for chronic conditions, population health, et cetera, this issue of non-adherence is really critical. Next slide. So there's much work that needs to be done to determine best practices for improving adherence, and a lot of work to determine what the causes of adherence are, because those causes can be very variable, from side effects, as we've already been talking about, to cost, to even just the patient not believing that they need to be taking the medication, and so on. So there's a need to match interventions with the specific patient's needs. Some of the interventions that are out there are things like pharmacist interventions, so having pharmacist counseling, for example, to ensure patients really understand the reasons for medications, the side effects. I mean, if you think again about that 12-minute primary care visit, it's pretty hard to do a decent job really explaining all of the issues related to medications. Patient portals, where patients can see their medication list, potentially have links to resources related to medications, potentially have ways to report back on problems they're having with medications in a more real-time way without having to actually try to get through on an office phone. Pill monitoring technology. So there's electronic pill caps that can capture how often the bottle's been open. There's even now mobile health apps that can text you when it's time to take your medication, or have interactive voice response to call patients to ask about side effects. So all kinds of things that are kind of just starting to come out. And particularly as we're talking about e-prescribing, I think that one of the things that's really starting to get built into these systems more and more is the feedback of adherence information to the ordering provider through technology. So being able to capture pharmacy fill data and display it to the physician as he or her is prescribing and doing medication reconciliation and other things, to me is a very promising way to have a better conversation in the office visit. Instead of saying, Mrs. Jones, are you taking your metformin? And the answer is yes. Then you would have data to say, well, it seems like you haven't filled it in 2 months. Let's talk about it. And having that data could really help open up conversations that might not be happening currently. So to me, that's a really important one as it relates to e-prescribing. Next slide. So adverse drug events and medication errors are a significant issue in the ambulatory setting. E-prescribing certainly has great potential to reduce medication errors, and we know the rates of implementation have really skyrocketed with meaningful use. But now is the time to really try to think about how to optimize its impact. How do we improve alerting? How do we minimize unintended consequences and ensure that the right functionality and decision support is in these systems to really ensure safe medication prescribing, administration, et cetera, and the best care for our patients. So I think those are the questions that we're going to need to really address as we go forward in this space. I think that is my last slide, actually. Yep. So thanks very much. Again, thanks, Mark and John, for inviting me to speak.
Rachel, it's our pleasure. That was excellent. Some questions have come in. If you have a few minutes, can we pitch some at you?
Of course.
Miriam Klein asked about your terminology. We're talking about serious errors. Does this correspond to the MERP Category E errors,
I would have to go back and look. That's a good question. It's been a while since we did those studies. We did not use the NCC MERP definitions. We had specific other definitions that we used in the study to classify significant versus serious versus life-threatening, but they generally map pretty well.
Great, thank you. This is a question from Scott Finley. It's about one of the functionalities that used to work pretty well with written prescription, but the question is, can we do it with e-prescribing? And it's about conditional prescriptions, like if you're not feeling better tomorrow, start your antibiotic. Is that doable with e-prescribing?
That's a great question, and I'm sure Ajit will have other things to say about that as we go forward. I mean, I think there's certainly ways to include special instructions on prescriptions to have those show up at the pharmacy and have those show up on the prescription. So I definitely think there's ways to have that happen. One of the challenges with those special instructions can often be, if prescriptions get renewed, for example, often the special instructions will just be copied and pasted essentially onto the renewed prescription when it may not be relevant anymore. So the answer is I think there's definitely ways to do it, but you have to be careful in how you do it so that it doesn't, again, end up leading to unintended consequences where these instructions that were maybe only meant for an initial prescription end up kind of lasting in perpetuity.
Right, thank you. This is a question from Ruth Martins. How can we curate the rules that will underlie when alerts should or shouldn't be shown?
So that is a great question. All the work that I showed you about the curation that happened at Partners Healthcare was a huge, as you can imagine, huge amount of work. And so when I talk about that study, a lot of people say, well, that's great, but how would we possibly do that at a small community hospital or even another bigger hospital that maybe doesn't have the resources to do that? So I strongly believe that we really need to be having some of these best practices for rules and things standardized at a national level, and potentially through something like an HIT safety center that could really say this is the best practice that we think all of the vendors should use or that all of the folks implementing should use. So I think there's a real opportunity there to start to create this kind of best practice knowledge base.
Yes, agreed. Question from Patricia Hale. Did you find acceptance was better for the interrupted alerts versus the non-interrupted, and if so, why?
So what we found was the interruptive alerts had this 67% acceptance rate. The non-interruptive, there was no way to actually know if providers did anything with that information or not. So it's hard to compare what the acceptance rate is for the interruptive versus non. There have been studies that have looked at the if you look at level 1 versus level 2, for example. So level 1 are those hard stops, those really bad ones. And if you make it a hard stop, it's going to be 100% accepted because you don't have a choice. If you make those just interruptive and not hard stops, their acceptance rates go way down. So you might be at somewhere around 50% acceptance for one that is pretty important. So that's where I think the real value is if, by having, well, one of the places of real value is by having hard stops for really important ones, you ensure acceptance, whereas if you just keep those interruptives, you're going to have a much lower rate. But it is hard to know whether those ones that were non-interruptive, that just passively displayed, whether people did anything with those or not. And I think that's one of the kind of prices we pay to try to minimize the interruptions, is that we realize we're passively displaying some of these things, and it's not going to be quite as effective, but we're okay with that because we're ensuring that they're really paying attention to the most important ones.
Yeah, and just to follow up on that, this is a question from Thomas Swanson. He says, can you speak to the litigation concerns if alerts aren't displayed at all or if they're shut off by the system somehow?
Well, I think that gets to my last point, right? So what we really want to make sure is the most important alerts that have the most safety implications are looked at and thought about and accepted when appropriate. And we know if we display all of them, that's not going to happen. We have very solid data to say that. So to me, the litigation concern is greater if you're alerting about everything as opposed to if you're being more selective. I think we need to think about this all in the context of what's best for the patient as opposed to, where's the risk of litigation. And I think what's best for the patient is to ensure that providers are really paying attention to the alerts that we think have the most potential clinical impact.
Right, good. Tejal, there's several questions coming in that we're not going to have time to get to, so I'd like to send those to you by email if it's okay. And I'd like to ask you maybe the last question from me. If you were able to repeat the study that you reported in 2003 about the incidence of medication-related problems, do you think today you'd find more problems, less problems, different problems?
Well, so it's a good question. I think the studies on medication error rates on prescriptions, for example, I think we would see that we have fewer. But I think on the adverse drug event side, first of all, a lot of those were non-preventable based on the way we looked at them. They were just, things that happened with medications that no one could have done anything to do anything about because we know drugs have side effects. So I think, those non-preventable ones would not change necessarily. The ones related to errors, the preventable ones, I think would be down because of the bigger implementation of e-prescribing since then. And then that last bucket about ameliorable, where symptoms happened and went on for a long period of time, I still think that's a significant issue, and we have so much more work to do on improving communication between providers and patients in the ambulatory setting that I'm not convinced that we've made much movement on those.
Interesting. Tejal, thank you so much. We really appreciate it.
Thank you.
I'd like to move to our next speaker. Dr. Erica Abramson is an assistant professor in the departments of Healthcare Research and Policy and Pediatrics at Weill Cornell Medical College. She has a major commitment to education as the Associate Program Director for Pediatrics and is co-director of the Fellowship Program in Healthcare Quality and Medical Informatics. At a national level, she co-chairs the EHR and Medical Informatics Special Interest Group of the Ambulatory Pediatric Association. Erica has more than 40 peer-reviewed research publications. Most of these are focused on how health information technology impacts prescribing safety. So Erica, thanks for sharing your findings with us today.
Great, it's my pleasure. I'm really excited to be here. Thank you for inviting me. So I'm going to present several bodies of work that I've been involved in, which really build off a lot of the themes that Tejal raised, and also add some new questions I think we should be looking at. So just by way of background, I'm sure almost everyone knows that the Electronic Health Record Incentive Program is really this unprecedented national policy that's promoting the adoption and meaningful use of electronic health records. And really importantly, in this context, two of the core requirements of meaningful use that providers must meet in order to be eligible for financial incentives are CPOE, which is computerized provider order entry, which is essentially entering prescription information electronically, and then e-prescribing, which is the direct transmission of prescription information to pharmacies, pharmacy benefit managers, or health plans. And of course, we all know that the goal of all these efforts is really to improve the quality, safety, and efficiency of healthcare delivery. Next slide, please. And so I think in this context, it's really striking how great the increase in electronic prescribing has been. So this is data from SureScripts, which issues a national progress report annually, and it shows just between 2011 and 2013 the changing rates of e-prescribing use. So in 2011, just over half, so about 58% of ambulatory-based physicians were using e-prescribing, and as of 2013, 73% of physicians were e-prescribing. And also, as of 2013, it's important to note that greater than 95% of pharmacies are now accepting electronic prescriptions, and there were 6 billion electronic prescriptions transactions just in that 1 year alone. Next slide, please. And so Tejal actually referenced this work, but I think it's a really important context for how necessary the move toward electronic prescribing has been. So this is a study that we did that was published in 2011 and actually covers the time periods of 2005 to 2006. And what we did is we studied handwritten prescriptions written by a total of 78 prescribers in the community setting. And these were physicians in multiple different practices, and they were physicians in multiple different states, so New York and Massachusetts. And we reviewed in total over 9,000 prescriptions, so manually reviewed all of these prescriptions. And the rates of errors that we found were quite striking. So in total, on average, there were 36.7 errors per 100 prescriptions. And in New York and Massachusetts, as we would have expected, there was no difference in the error rates between the providers. What I think is also really noteworthy about this study is that these error rates actually didn't even include illegibility errors, which we defined as a prescription field that was illegible to the point that 2 reviewers were unable to, with any degree of certainty, determine what that field read. And those error rates occurred on average more than 1 time per prescription. So really, really striking. I think what's also important about this work is that a lot of the work on medication safety, both in the inpatient setting and in the ambulatory setting, often starts with academic medical centers or major hospitals. And this work is grounded in the community. And I think it's really important that when we're thinking about studying ambulatory prescribing safety, that we not only include hospitals and obviously affiliated outpatient practices, but also look in the community where the vast majority of prescription writing occurs. And then certainly, as Tejal was saying, moving beyond that and beyond specialty practices to some of the other what are considered ambulatory errors, ambulatory centers. Next slide, please. So I'm going to spend a few minutes on this slide because I think there's multiple different important points. This was actually a series of studies that, again, we did in the community. And so we looked at primary care-based providers in the outpatient setting, and we studied them at baseline, so before they adopted electronic prescribing, and then 1 year after implementation of electronic prescribing systems. And we studied several groups of providers. So one group of providers elected to adopt a standalone e-prescribing system. And this study was conducted again around the 2006 time period, so before a lot of the meaningful use requirements were issued. And standalone electronic prescribing systems are systems that are really solely designed for the purpose of electronic prescribing. They're not integrated into an electronic health record. And then we studied a similar group of providers, but this group of providers had voluntarily decided that they were going to adopt an integrated electronic prescribing system, so one that's embedded in an electronic health record. And because of that, has a lot of the support that an electronic health record might offer. So for example, we'll have a lot of the patient's laboratory values, some of the medical conditions, other things that you might think would aid providers at point of care prescribing. And a couple of things we found from both of these sets of studies. So I think the first thing to look at, and again supporting some of the other work from the study I just showed you was that there are really, really high rates of prescribing errors at baseline. So among the providers that we looked at that adopted a standalone electronic prescribing system, their error rates were actually 42.5 per 100 prescriptions to start. For the integrated groups of prescribers, they also had high error rates, not quite as high as the first group. Their error rates were 26 per 100 prescriptions at baseline. Again, really underscoring the danger that can be associated with handwritten prescriptions. We then, as I mentioned, looked at what happened to e-prescribing error rates 1 year after implementation. And the results were pretty striking. So among the standalone group, we found nearly a 7-fold decrease in prescribing errors, so from 42.5 to 6.6 errors per 100 prescriptions. And again, a large increase, 1.5-fold decrease in errors among the integrated e-prescribing group. So their error rates went from 26 to 16 per 100 prescriptions. We also were very interested in the way that the two systems seem to compare differently in terms of decreasing error rates. So when we actually adjusted the error rates at baseline, since the standalone prescribers had a higher rate of errors per baseline, when you adjusted these statistically and then compared how each system did, actually the standalone system had a more significant reduction in errors, which we found was really, really interesting because a priori we had hypothesized that, of course, an integrated system with a lot more decision support available to providers would have been the better performing system. And so I think for us, this raised a really important set of issues that we wanted to explore more in depth. And so we started talking with the providers and the vendors, and we found a couple of different things. First thing that we found out was the way that providers were trained on the systems and the way the systems were implemented was very different. Actually, the standalone e-prescribers had much more training up front, much more workflow study in the practices done, and a greater reduction in their workload prior to go live of the standalone system. We also started to compare at a higher level the clinical decision support that was available in both types of systems. And at the time the integrated system went live, there was actually less clinical decision support that was available. All the features, they turned them on over time, so that the standalone e-prescribing system, even at a year, actually had more clinical decision support available. And so putting those factors together, it started to make more sense to us why we might have seen such a difference in the way the two types of systems performed. Next slide, please. And so I think that one of the things that we've taken away from this series of work in the community is that any quality or safety impact of health information technology really has to be thought of as a result of multiple interacting factors. So it's not just presence or absence of a technology, but really we need to be probing and thinking about how that interacts with the user and how the healthcare organizations are interacting with these technologies. And that really, when we're talking about studies in these settings, the best and most rigorous evaluation are going to capture the host of these kinds of factors to really explain the results more in depth. Next slide, please. And so we published a model that we use for many future studies called the triangle model, which really shows pictorially what I was just talking about. And so when we study systems, we look not just at its impact on patients in terms of quality and safety outcomes, but start to think about the interaction between that technology, the organization, and the provider in order to better understand the types of outcomes that we are seeing. Next slide, please. And so in conclusion for this body of work, I think our results show that e-prescribing certainly is effective in the ambulatory setting and that we need it based on how unsafe handwritten prescriptions are. And again, to really understand the full impact of health IT, we have to be understanding this interplay between technologies, providers, patients, and organizations. I think lastly, what I like to think of is that we need to start thinking more about doing comparative effectiveness research with health IT as the intervention. So comparative effectiveness research tends to be head-to-head comparisons and typically is focused on medications or specific, let's say, surgical interventions in order to understand which is more effective. And I think we also have to start thinking about health information technology in that same light and doing comparisons of different types of systems, different types of decision support to really understand what is going to be most beneficial and safe for patients. Next slide, please. So I want to switch gears a little bit, and again, sort of building off some of the concepts I've talked about with the triangle model, to focus on a different body of work that we did, which was really looking at when you implement these electronic prescribing systems, what's the impact on safety over time? And also, how do providers perceive the implementation of these systems? Because again, I think it's really important as all of this adoption and use of electronic prescribing is occurring across the country, that we understand how the people who are using these systems are going to be interacting with them and what their experiences are. Next slide, please. So it's clear that transitions are challenging, and there's certainly significant literature in this area. So for most providers across the country, of course, they're going to be going from paper-based prescriptions to writing prescriptions electronically using computer for the first time. And this is, of course, bound to lead to a lot of frustration. I think it's also important to recognize, though, that there's also going to be a body of physicians who generally have received less attention from research, who are going to be going from one type of electronic prescribing system to another type of electronic prescribing system, and then for everyone, sort of switching continuously between system versions that are frequently getting updated, especially in response, at least recently, to some of the federal requirements for meaningful use. And that all these transitions are going to be challenging. And I think we have to be very cognizant as a nation moving forward that we understand what the safety implications for our patients are going to be. Next slide, please. So again, I'm going to spend a few minutes on this slide because this was actually a series of studies that we did. And what we did is we actually studied not community-based providers for this series of work, but we actually studied academically affiliated providers in an outpatient setting. And we looked at what happened to prescribing error rates over time. Now, at the start of the study, the providers in this study were actually using a locally developed electronic prescribing system integrated into an electronic health record. And what I mean by locally developed is that the system was designed and developed by one of the physicians who worked in this ambulatory practice. And the system was very well customized to the workflow of that clinic. It actually had very minimal clinical decision support, so only not very many bells and whistles, so to speak. The decision support around prescribing was actually, there was default formulations built into the system, meaning that a provider could type in a medication and the most common sort of formulation would appear. And there was also some formulary support, which I'm not going to spend too much time on, in the prescribing system. And there was a huge amount of resources and IT interventions that were put into place to transition this clinic over to a popular commercially developed electronic prescribing system. So the system that they transitioned to is one of the top outpatient prescribing systems in the country, also integrated into an electronic health record, and then had very, very robust clinical decision support, mostly in the form of alerts, but also with default dosing and formulations that was intended to help improve prescribing safety. And the hospital that this clinic was affiliated with spent a lot of time transitioning this system and rolling it out into various practices. The site that we studied, which was the main primary care site, was one of actually the last sites to go live on the system, with the thought that because so much prescribing occurred here, they really wanted to iron out a lot of the kinks in some of the specialty sites before rolling it out to this group of providers. And what we found when we studied the prescribing was actually very, very interesting and raised some concern for us. So what we did is we actually, again, manually went through all these prescriptions to look for prescribing errors. And what we found is similar to what we had seen in the community-based providers. Actually, the academic-affiliated prescribers in this study had very high rates of errors at the beginning, so close to 42 errors per 100 prescriptions. And we saw that over time, at each step, so 3 months, 1 year, and 2 years, if you looked at all the prescribing errors in total, there actually was an ongoing decrease in prescribing errors, with pretty low rates of prescribing errors achieved at the 2-year mark of 3.8 per 100 prescriptions. And again, this was reassuring to us, and that certainly implementing a electronic prescribing system that's commercially available with robust clinical decision support would indeed reduce errors over time. We were also a bit struck by the fact that we were continuing to see declines in errors, and I think that was in large part due to a lot of the system refinements that the organization was making based on feedback from providers. But what we also noticed was that there was one type of error that was predominating, and those were inappropriate abbreviation errors. So that was providers writing on a prescription an abbreviation that was not JCO approved, for example, QD. And so when we excluded those types of errors, what we found was actually quite a different story. So when we looked at the error rates at the 3-month period, so pretty soon after transition, we actually found a significant increase in errors. So errors went from 3.6 to 7.7 errors per 100 prescriptions. And even at the 1-year mark, there was still a higher rate of errors than there had been at baseline, 4.9 errors per 100 prescriptions. And this was also statistically significant. It was only at the 2-year mark when we looked at these subgroup of errors that didn't include inappropriate abbreviation errors that we finally saw the reduction in errors that everyone had been anticipating would occur once we adopted the more robust clinical decision support that was part of the electronic prescribing system from the vendor. Next slide, please. And so for us, I think there were really important implications that nationally we have to be aware of. And I think one of those is that transitioning may pose very important safety threats to patients. And I think we really have to be thinking as an organization about studying the transition period and putting in all sorts of protections to make sure that the transition is associated with the least amount of threat to patients possible. The second thing I think that we learned from this work is that it really may take a lot of time to see anticipated safety benefits. And that's really important from an expectations management perspective for both providers and organizations, that it may not be at 3 months that you start to see the safety benefits that you anticipate. And I think it's also noteworthy in that these were experienced e-prescribers. It may be that prescribers who are used to writing on paper, it may take even longer compared with those who are already sort of comfortable at least doing basic prescribing on computer systems. And lastly, I think it's clear that organizations have to monitor errors and continuously make refinements, as the organization we studied here did, in order to minimize safety threats to patients. Next slide. So I had mentioned earlier that we've really been employing this idea of the triangle model and wanting to understand why we might be seeing some of the patterns that we're seeing. So one of the things that we did for this series of studies was we actually interviewed providers over time. So we interviewed them at 1 year and 2 years after going live on the new system. And we also watched them. We did field observations studying providers on how they use these systems. And our goal was to help to develop some lessons learned in terms of best practices for implementation and things that organizations need to be thinking about when undergoing such a transition between systems or adopting a new type of system. Next slide, please. So I'm going to present these as some of the lessons that we learned, and wherever possible, I've actually tried to include some quotes from providers, because I think these could be actually much more powerful in sort of capturing the sentiment of the lessons that we were hearing. So I think it can be sort of verified with the quantitative data is that transitions are much more difficult, or maybe much more difficult than expected. And our providers said this again and again, that they had thought that because they already were using an electronic prescribing system, that it wouldn't be so hard to transition, and it was. And the other thing that our providers said is that the perceived decreases in efficiency may last much longer after go live than providers or organizations may be thinking about. So as one provider said, I'm losing 3 to 7 minutes per patient and have a similar 15% reduction in productivity on a daily basis. After a year, I'm still behind. Now, I should say as part of the implementation process, provider schedules were reduced in the first month after go live by 75%, 50%, and 25%. But even that, many providers said was not enough, and that they would have needed a longer period of time to become efficient. The good news is that after this, for our providers around the 2-year mark, they really were as efficient as they had been at baseline, so that efficiency did eventually come, and as did the increased familiarity with the system, but it just was at a much slower pace than anyone was thinking would happen in the beginning. Next slide, please. I think another point that came out from our work here was that training requirements for providers are really extensive, and they really have to be an important part of system rollouts in order to ensure that providers are comfortable and patients are going to be safe. So again, many people focus on these initial requirements of training, but what our providers said, and I've done other work in other settings, and providers have all echoed the same sentiment, is that really it takes them a while to master the basics. And so if you try to train them on basics and advanced features at the same time, they're only going to be able, most of them, to master the basics, because that's what they're really eager to learn so that they can sort of get back to their regular workflow. So as one provider told us, in training they did show me shortcuts. The problem is they trained me on everything at the same time. So many providers felt that a year or even 2 years is a time when they wanted everyone to go back and teach them some of the system shortcuts that they were not aware of even existed in order to help make their workflow better. The other thing that we found that was very interesting is even among providers who knew how to customize the system to, for example, put only the medications that they commonly use in certain fields, or to pre-populate certain templated instructions that they use frequently, that they didn't have the time, they didn't feel like they had the time to take on this work. And so it was only if an information technology support person actually did that work that they were going to adapt those features. And these are features that may, in fact, make prescribing safer. For example, if you have a lot of choices on a drop-down menu, customizing it so you have your most frequent medications that you're using at the top may help to mitigate some of those errors. Same with pre-populating prescription fields, which can cut both ways. But if you have specific instructions that you like to use in prescriptions, certainly having those as part of your prescription template can be very useful. Next slide, please. Then third, and I think this underscores a lot of what Tejal spoke about earlier, that system design really greatly impacts provider satisfaction and also does have important safety implications. So our providers always consistently mentioned a few features that were very frustrating to them and which they felt like negatively impacted on safety. So the first was that there were far too many medications on drop-down lists, and this was an easy source of error with simply picking the wrong medication from a list. Or, which was happening in the first year of the system, many providers, if they became overwhelmed with the number of choices that were on the screen, simply pulled out paper prescriptions and bypassed the electronic prescribing system altogether. A second thing our providers mentioned in terms of system design was really inflexible medication search engines. So a lot of providers gave the example or an analogy of Google, where if you type a medication or some sort of name into Google that it doesn't recognize, it'll give you alternative choices. Well, at least the system that we were using, which again is a pretty popular national system, the medication search engines were completely inflexible. So if they didn't know how to spell a medication name, there were no choices that were provided, and they would have to go and Google and use other resources to try to figure out the medication name. Many of them focused on the mouse clicks, and that there were many, many mouse clicks, and this was a big source for error. And of course, as Tejal mentioned, alert fatigue. So as one provider said, when 5 alerts come up and you've got to get the patients their prescriptions, it's hard to sort through. And so over-alerting was a big reason why providers were just sort of blowing past the safety features that were part of the system. Next slide, please. And lastly, I think speed and efficiency are something that are key and may not be always what's thought of when we're designing these electronic prescribing systems, but for providers to use these systems optimally, that's one of the things that they really need. So the features that our providers loved were the ability to directly transmit prescriptions to pharmacies, and then automatic refills and telephone refills, which were made much simpler through an electronic prescribing system. What was very interesting and that they also pointed out, which again I think is an area safety-wise that we all have to be cognizant about, is that part of what made it more efficient for them is that the work often shifted from themselves and having to rewrite refills, et cetera, to other staff, that because the prescriptions were now electronic, could sort of simply click or be logged into the system and send the prescriptions off. But I think that everyone was cognizant of the fact that there were times when errors were made as a result of the fact that they weren't the ones actually writing the prescriptions, or that pre-populated prescription information or instruction information was getting sent off without anyone reviewing it. Next slide, please. And so I'd like to conclude with, I think, the following sentiments. So first, I think we all have to recognize that for everyone transitioning, even for experienced electronic prescribers, resource and training needs are going to be extensive and going to be ongoing. And a key to making this whole process safe is to recognizing that. I think also expectation management is key, that organizations need to be vigilant about monitoring for errors, and that we really have to track how these health IT systems are doing as they're implemented over time. I think next is this idea that we really need to be studying technologies and thinking about the complex user interfaces and functions, and how we really need to be simplified to better fit physician workflow. And I think it's the same idea with the alerts, that we have to find the right balance between meeting all the regulatory requirements, but also making these systems manageable in a way that physicians and other providers can use them. And I think lastly, it's certainly going to be important to configure clinical decision support to meet user needs in order to achieve the potential safety gains that we've seen. And again, I think a lot of that goes back to alerts, which tend to be the most common type of clinical decision support. And whether it's focusing on the most high severity errors or even in the most high frequency errors, we have to think nationally about better ways to do this and to disseminate this across a larger audience, so it's not just major institutions that are able to do this work. And I think that's my last slide.
Erica, thank you. That was excellent. Really enjoyed seeing that data. A couple of questions for you. One from Philip Fallis. In part one, where you were showing us the data that compared integrated e-prescribing to non-integrated systems, Did the integrated systems ever catch up to the standalone system in safety?
So we have not done the follow-up studies. We stopped at the 1-year mark. Again, when we went back to the vendors and the communities, what we did find is that they, first of all, they had started turning on more and more clinical decision support, hopefully to better help providers. But one of the big things that the community took away is how do you actually implement and train these systems, train providers on these systems better. So the protocols going forward in terms of training providers as these computerized prescribing systems were rolled out in the communities actually matched the standalone system. So they had extensive workflow mapping ahead of time. They had extensive training. They had physician champions, and they had a reduced workflow for a long time after go live occurred, with the hope that hopefully there would be a better improvement in safety as providers use these systems. I think one of the things that we've speculated is that providers, what they learn in the beginning is often what they continue to do throughout the course of their prescribing career, unless you go back and really retrain them. So getting that training right in the beginning, I think, is key.
Good. Okay. A couple questions about prescribing and transitions of care. What role do you think patients might play in helping do this reconciliation? This is a question from Patricia Hale. Are patients starting to use personalized health records that can be interfaced with the physician's record to do that reconciliation?
I think that there's great potential for that. I can tell you certainly where I am at Cornell, we've had a big push to get patients enrolled on our outpatient portal system that links with the electronic health records. And so I think getting patients more involved in their reconciliation of medication is certainly a huge part in making this whole process safer. I also think, at least anecdotally from a lot of the work that I've done and some of the research I've done, but also work I've done with trainees, is that providers don't always recognize the importance of medication reconciliation. And so one of, I think, the hazards with these electronic health records, and especially where multiple people have access to medication lists, is that unless you really clean up those medication lists at every visit, there's the potential for old information to be remaining on the medication reconciliation form, and providers don't always spend the time doing it. So I think educationally, sort of not just from the patient end, but also from the provider end, it's clear we have a lot of work to do on the medication reconciliation front.
Yeah. Maybe one last question, again, from Philip Fulis. Well, you talked about when showing people a list of medications to choose from, if you could constrain it a little bit, it might help them. But what is the right number of medications to show on that constrained list before it gets confusing?
I don't know that there's I don't know if there's research on a magic number, but I can tell you, for example, this came up with providers in this study with vitamins and Tylenol. There was just an endless choice of medications, and there were some formulations that were on there, for example, that were no longer even prescribed at pharmacies. I'm a pediatrician. They changed the way that Tylenol is prescribed, and yet there were still old concentrations on these drop-down lists. So I think being cognizant of removing medications that are not prescribed or that are going to be very rarely prescribed is one thing to do. I think the other thing that our providers mentioned and has been mentioned in many studies that I've done is prioritizing them so that the most common formulation comes up first so that it's much easier to find. I think if there seems like there's no order to the way that medications are presented in a drop-down list, it can also be very challenging.
Yeah, yeah. Excellent, Erica. Thank you so much.
You're welcome.
Our last speaker today is Ajit Davli. Ajit is the Vice President of Clinical Quality at SureScripts. Ajit built and now runs the clinical quality program there, which is focused on the three fundamental pillars of e-prescribing: accuracy, efficiency, and patient safety. At SureScripts, he's been involved in a variety of product management, products, certifications, implementations, and standard developments. In 2006, he managed SureScripts' Federal Medicare Modernization Act pilot program that evaluated advanced electronic prescribing standards. Ajit received his Doctor of Pharmacy and his Master's of Business Administration degrees from Shenandoah University in Winchester, Virginia. Thanks, Ajit, for joining our panel. The floor is yours.
Thank you, Matt. I appreciate the opportunity. I have two specific goals today. First, I want to briefly describe the SureScripts e-prescription routing clinical quality program. And second, I want to discuss some of the clinical quality issues that we see on a regular basis and then outline some potential solutions. So SureScripts is a robust and fully developed clinical quality program. Every quarter, we review a statistically significant sample size of prescriptions flowing through the SureScripts network. We review these prescriptions against our established quality guidelines. We score them using a consistent scoring methodology and a quality-related event terminology. We then create quality report cards, and these report cards get sent out to each and every EHR system connected to the SureScripts network on a quarterly basis. We just do not stop there. We engage with the EHR vendors on a regular basis. We provide them their own scored data examples. We share proven best practices, and we work with them to create joint quality improvement plans and execution strategies. Now, over the past 4 years, we have learned quite a few things working with the EHR vendors. More importantly, we have a good understanding of what works and what does not work. That said, and unfortunately, I do not have one single silver bullet solution that I can point out that will fix all the quality problems that we all see right now. However, and this goes back to what Tejal and Erica said, there are two specific actions that we have learned over the past few years that can go a long ways in terms of significantly reducing the quality problems that we observe. Namely, consistent and regular end-user training, and second, regular enhancements to the end-user interface to better incorporate prescriber workflows. Now I want to shift your attention to our White Coat of Quality Award program. This is an annual program that was created to honor and recognize EHR vendors that are going above and beyond to improve the quality of e-prescriptions generated by their end users. There are 4 basic requirements. 1, a commitment letter from the CEO or a senior executive demonstrating their commitment to the goal of 0 errors. Second, documented evidence of end user training. Third, end user interface or back-end enhancements. And fourth, pre and post measurements to document the impact of the interventions within that calendar year. I must say that our program has been well received by the industry, and in 2013 we awarded this honor to 51 EHR vendors. we will soon be releasing our 2014 awardee names. Next slide, please. I now want to slightly shift gears and, as mentioned earlier, discuss some of the quality issues that we observe. So, next slide. All right, first one, sending an accurate and complete prescription drug description. Sometimes prescribers are unable to find the drug description that they want to prescribe within their EHR systems. Now, drug description is a required field for the NCPDP script standard. Hence, the EHR system will not allow the user to move forward until a selection or an entry has been made. Now, oftentimes, we see prescribers selecting a placeholder drug description name and then including the actual drug description name in the free text notes field. Definitely a problem. Now, on the other hand, there are applications out there that do allow their end users to free text the drug descriptions. And many a times, these free texted drug descriptions are incomplete or abbreviated, and then this triggers a pharmacy clarification callback. So what are some possible solutions? Well, EHR vendors must regularly download their drug database updates, at a minimum once a month. EHR vendors must also proactively pass these drug database updates downstream to their end user practice site locations, also on a regular basis. And finally, EHR systems must limit their end users' ability to free text drug descriptions unless absolutely needed. Next, proper use of the patient direction SIG Builder tool. Most current day EHR systems have deployed a SIG Builder tool, basically a series of drop-down menu options to create a structured SIG data string that then enables better clinical decision support checks. Now, make no mistake, the SIG Builder is a very important tool. However, the constraints of this tool are also well documented in the peer-reviewed literature. Hence, we sometimes see incomplete SIG instructions or supplementary and conflicting SIG information getting sent in the free text notes field. Some possible solutions include full adoption and implementation of the structured and codified SIG format as available in the NCPDP script standard can go a long way in terms of reducing this problem. In addition, vendors must allow their end users to free text additional SIG instruction that then gets appended to the structured string generated by the SIG Builder tool and then gets sent as one single data string within the designated SIG field only. Next slide, please. Appropriate selection of the quantity and the quantity qualifier values. Oftentimes, we see prescribers send a generic or a non-metric quantity qualifier value in the e-prescription message. Now, please allow me to illustrate this point with an example. Prescriber writes a prescription for amoxicillin 250 by 5 mg per ml oral suspension. Take 5 ml by mouth 3 times a day. They then select a quantity value of 1 and a qualifier of EA, basically a generic for 1 bottle. They also do not include any day supply information in the message. Now, as most of you might know, amoxicillin 250 by 5 oral suspension comes in 3 commercial packet sizes, namely an 80 ml bottle, a 100 ml bottle, and a 150 ml bottle. Hence, going back to the example I just said, the pharmacy would not know what exact medication quantity to dispense and would most likely then call the prescriber's practice for clarification so that the pharmacy, does not run into third-party audit problems later on. For this reason, we ask EHR vendors to display all available commercial package sizes along with their metric quantity values for certain specific dosage formulations like ointments, creams, or suspensions, and then only send the metric quantity value in the message after an appropriate selection has been made by the end user. In addition, We also ask EHR vendors to accurately map their internal proprietary quantity qualifier values to the appropriate corresponding NCPDP quantity qualifier list. Next slide, please. Contradicting day supply and quantity information. Sometimes we do see contradicting day supply and quantity or SIG information, like the example I have on the screen. Other times we see default values getting populated in the e-prescription, such as a 0 or a 365 for day supply. Now, day supply is an optional field and does not have to be sent in the message. Day supply should only include length of therapy per prescription fill information. Finally, EHR vendors should implement clinical decision support checks to alert the prescriber when an erroneous value is populated. Next, clinical or conflicting information sent in the pre-text notes field. This is by and large the most common pain point reported by the pharmacies. Now, oftentimes, we see clinical information that has a designated data field within the e-prescription message getting populated in the pre-text notes field. Now, think of this for a minute. From a pharmacy perspective, the best case scenario is a workflow disruption that then might result in a clarification callback to the prescriber. However, the worst case scenario is a potential patient safety incident if the pharmacy dispenses the wrong medication, if they totally miss the information in the notes field or make an assumption on behalf of the prescriber. I get this. Free texting is easy and very convenient. However, here are some proven best practices that have successfully worked in the past. Number one, consistent end-user training. I've said that before. Data monitoring, and then feedback to the prescriber. Number two, clear labeling of the pre-text notes field. Do not label this field as additional instructions. The prescriber will put instructions if you label it that way. Number three, consider adding an alert or a watermark reminder statement to better educate the end user on appropriate usage. And finally, consider codification of the commonly used notes by your end users and then present it as a drop-down menu option rather than simply displaying an easy-to-use free text box. Next slide, please. Consistent use of the final prescription summary screen. Now I understand this is much, much easier said than done, and this involves an additional click for the prescriber. That said, a little bit of upfront work can go a long way in terms of reducing downstream problems at the pharmacy and, of course, by extension, at the prescriber's office. Hence, we strongly encourage enforcement of the final review screen by the EHR vendors and urge all prescribers to carefully review their prescriptions one last time before they send them over to the pharmacy. Next, enabling electronic prescribing of controlled substances. This really is a separate webinar topic by itself, given all the moving parts and the details, including third-party vendor audits, two-factor authentication, identity proofing, and so forth. SureScripts has recently created a new informational website called getepcs.com that prescribers, pharmacies, and their vendors can access to get additional details. I urge you to go onto this website and take a look. Now, my goal today is to just simply inform you that EPCS is very much legal and that we continue as a network to see a steady growth in terms of EPCS transactions flowing through the SureScripts network. However, from a quality standpoint, enabling EPS has huge benefits. EPCS can eliminate dual prescription writing workflows and enhance efficiencies at the prescriber practice and also at the pharmacy. And EPCS allows better tracking of controlled substance prescriptions that then can result in fraud prevention. So for these reasons, we strongly encourage industry-wide adoption of EPCS. Next slide, please. Implementation of Rx change and Rx cancel message. The Rx cancel message allows the prescriber to electronically cancel their patient's existing prescription therapy at the pharmacy or cancel prescriptions that may be on file at the pharmacy. The Rx change message allows the pharmacy to send an electronic prescription change message to the prescriber requesting a prescription change. The pharmacy can initiate this message for 3 specific reasons: formulary compliance, therapeutic interchange, and then requesting the prescriber to initiate a prior authorization. Now, unfortunately, we have not seen any adoption of these 2 message types. Make no mistake, the standard is ready, the networks are ready, and over the years and in my interactions with other clinicians, including prescribers and pharmacies, I have no doubt that there is a clear business and clinical need for these 2 message types. So I want to use this platform and urge the industry to implement both these message types as soon as possible. With that, I conclude my prepared remarks. Mark, back to you. Again, thank you for the opportunity.
Thank you, Ajit. That was interesting. A couple questions have come in, if you have a few minutes. Apparently, some systems don't have free text fields at all. So this is a question from John Sanderson. How do you, for example, order a medication needs to be tapered if there's no free text field?
So when it comes for, so this is a very good question, and there are a couple of answers. Right now, the SIG standard as implemented, or the SIG field as available within the NCPDB 10.6 standard has a character limitation of 140 characters. However, in the future versions of the script standard, that field length has been increased to 1,000 characters. So that's one way to handle sliding scales and tapered dosing. Also, the second thing is, when it comes to free texting, there is always this problem of end user taking the shortcut. So the only answer that I have is better education of the end users. And right now, if the SIG standard, if you cannot write a SIG within the 140 characters, it's best to fax it or send it via paper.
Okay. I'd like to ask you a question about the kinds of data that you collect. Do you get a feel for the number of medication errors written by prescribers? Is there a difference depending on how old the prescriber is or how recently they did their training?
So we haven't looked at prescriber-specific data. However, we have data around EHR vendors connected to the SureScripts network. We do not share these numbers publicly at this point in time. We share these numbers back with the prescriber EHR vendors. But I don't have a good sense in terms of the prescribers. However, I have good reasons to believe that, the more the prescribers are e-prescribing, the better they are in terms of quality and error rates.
Okay, very good. We're out of questions, Ajit. Thank you very much. I'd like to thank all our panelists. This has been a terrific session, a lot of data conveyed. John, I'll turn it back to you to wrap things up.
Great, thank you, Mark. And thanks again to all of our speakers, as well as Mark Graber for moderating. I just wanted to close off today's webinar and just let everybody know that our third webinar in the series will be Thursday, February 19th, 1 p.m. Eastern Time. The topic is on interoperability, advancing health IT safety and quality through interoperability. And we've got 3 presenters lined up: John Halamka from Beth Israel Deaconess Medical Center, Scott Stewie from Cerner Corporation and the Commonwealth Health Alliance program, and Eric Heflin, who will be presenting on Healthy Way. He's the Chief Technology Officer there. So we'll thank everybody for attending, and have a great weekend. Bye-bye.